Welcome to the Cummings Graduate Institute's new podcast. We are calling it Disruptive Innovators, Working to Move the Needle on Integrated Care. Cummings Graduate Institute is a private, accredited, nonprofit university that offers the Doctor of Behavioral Health program in a 100% online format. CGI is focused on moving the needle of integration forward through advanced research, education, and training, including continuing education and workforce development initiatives. Our vision is to improve the way the world experiences healthcare by raising awareness about what integration is and by sharing best practices for disrupting antiquated models of care delivery. Doctors of Behavioral Health, DBHs, are trained to design, implement, and evaluate clinical, financial, and operational changes to care that accomplish the quadruple aim of healthcare improvement. This podcast represents discussions among subject matter experts, integrated care providers, and the patients we passionately advocate and care for. Today's episode focuses on integrated pediatric care, which refers to the integration of medical and behavioral or mental health services for children, adolescents, and their families in traditional pediatric care settings. Professionals involved in pediatric integrated care may be working collaboratively in a variety of settings rather than all under one roof. And the goal of pediatric integrated care is to achieve the highest level of collaboration between advanced practice nurses, child and adolescent psychiatrists, family practitioners, mental health therapists, nurse practitioners, pediatricians, doctors of behavioral health, and other professionals, including occupational therapists, physical therapists, speech and language therapists, and developmental behavioral pediatricians. There are a lot of professionals that children and adolescents and their families need to get the care that they deserve. So today, I would like to warmly welcome and introduce our guest, Dr. Melissa Johnson, who is a licensed professional counselor and a doctor of behavioral health in the state of Arizona. She has received a 2-year certificate in infant family clinical practice from the Harris Infant and Early Childhood Mental Health Training Institute. Dr. Johnson is a clinical supervisor for an outpatient mental health clinic for children and families and has worked part-time at Canyon Pediatrics, delivering integrated care services for over 4 years. She enjoys the opportunity to collaborate with the other doctors to provide comprehensive care. She has almost 2 decades of experience providing mental health for patients across the lifespan. So Dr. Johnson, thank you so much for joining us today.
Thank you for having me.
Absolutely. Can we start by having you give us a little bit of a description about the setting at Canyon Pediatrics and the integrated team structure?
Yes, absolutely. So Canyon Pediatrics is pediatric primary care, outpatient, and there are 2 clinics. I just work at one of them. And there is a pediatrician, MD, and a PA at the one that I work at.
Okay, so you don't have additional providers. There's no psychiatric provider, for example, or a PT or OT, correct?
Mm-hmm.
Okay. Tell us a little bit about the essential skills that you had as a DBH that other non-integrated clinicians would have struggled with in the integrated setting?
Sure. The first thing that I think of is I was really able to hone my assessment skills in the DBH program. Mostly how and where to identify what to target first with when they're coming in with an issue or a problem. And then knowledge of assessment tools. I don't think typically practitioners use assessment tools, and also how to speak to physicians, how to understand the medical language and know when to say something, when not to say something. Yes, and what to say.
Tell us a little bit about the assessment tools that you generally use and Do you use them with everybody? For example, can you give us a little bit of information about how you use assessments?
Sure. The main ones that we use are the PHQ and the GAD,
Mm-hmm.
Patient Health Questionnaire, and the Generalized Anxiety Disorder.
Mm-hmm.
Those are the Patient Health Questionnaire, for people that don't know, is to screen depression, and the GAD is to screen anxiety. We will occasionally use the MChat, which is a developmental screen for young children that potentially may have autism, and it's just a screen. So if a child would screen positive on the MChat, we would refer them out for further screening by a developmental pediatrician.
Mm-hmm. How easy is that to get someone in to see a developmental behavioral pediatrician in the state of Arizona?
Yeah, in the state of Arizona, it's not as easy as we would like. They have them for under Medicaid, which in Arizona is Access. They have it available for 5 and under at mostly at Phoenix Children's Hospital. They don't take referrals for over 5 years old. There are a couple other places that I know that they use to refer. There's not really, for Medicaid, there's not really places to refer them for older than 5.
Mm-hmm. So I wonder about that for kiddos who, have not been identified or maybe are on the autism spectrum, but have very high functioning, capabilities, and maybe look a little bit more like Asperger's, but then get into school, which 5 is school age. And so you're getting into, some of the behavioral difficulties that show up at, kindergarten. So how do you work with those kiddos?
So I do get a lot of referrals from the physicians for school issues. I typically help the parents advocate, look at their IEPs, which stands for individualized education plan. And I'll see if they don't have an IEP, I'll help assess whether it's a developmental issue or if it's an anxiety issue, because a lot of the children that I see at my clinic, they have Spanish speaking parents, and they have been, I'm going to say, thrown into school without the English language and are expected to learn school and learn the English language, which, as you would know, can create a lot of anxiety and issues around school. They also have trouble reading the English language. Even though they learn how to speak it, they have trouble reading it, and their parents can't help them with their homework. A lot of times it's an older sibling, so we have a lot of those kinds of things going on. So I just help, really, like I said earlier, it's primary care, so I'll help assess where the need is and then direct it out where it needs to go.
Yeah. And I would say that's one of the things that is a big adjustment for a person who's coming in with, sort of a case management background, or, somebody who is used to doing a more active role in, care navigation, that, as a pediatric behavioral health consultant, you have to really refer out and, maybe even connect individuals, if they're Medicaid eligible, with care navigators, and not be the care navigator yourself.
Yes.
Yeah. That's a hard one. I had a hard time with that when I was working in pediatric, as a behavioral health consultant, during my doctor of behavioral health training. In my practicum setting, I had a hard time with that, because often I would find that the referrals I was sending folks out to weren't as bought into or weren't as passionate about getting folks to where they needed to go. And so people would end up in that revolving door, coming back for what isn't a medical need.
Yes.
Coming back for that social need.
I like to keep them if I think that I can help them through it, about, I would say I don't go over 5. If I can keep it between 3 and 5. Sometimes it's good with 1 appointment. I don't really go more than 5. If I see it going that way, if I think, "Oh, I can do this in 1 or 2," and then it takes a couple more, that's okay. But I do that for that reason, because you're talking about access to care.
Yep.
They don't typically follow through a lot of times
Mhm.
with the referral. So if I think that I can knock it out, and I know that they're gonna come back and see me, I'll go ahead and do that.
Yeah, that makes a lot of sense. I kind of leaned in that direction myself.
Yeah.
So, talk a little bit about the handoff to referrals. So, if a family or a child or adolescent needs more intense mental health care, what does that look like? How does that handoff get
So,
coordinated?
yes, that's really, calling outpatient behavioral health, and I direct them to their insurance card and
Mhm,
have them call their insurance card.
mhm,
A lot of times I'll invite them to come back,
mhm,
um, just so that I can see if they did follow up.
mhm,
And most times they do.
mhm.
They do.
That's
Sometimes they don't at all, but if they come back to me, then they have typically followed up. But that process can take a long time. You call the insurance card, they give them the numbers, then they have to call those numbers, they have to set up an intake.
yeah,
And depending now, what type of insurance they have, if they have Medicaid or if they have private insurance, that looks different also.
absolutely. Yeah. Do you have do you find that you have an easier time getting folks who are Medicaid eligible into an outpatient mental health therapist versus someone with a third party insurance like Blue Cross Blue Shield or United?
I think it's fairly the same. I actually think there's more red tape with Medicaid.
Really?
Mhm.
Okay. That's interesting. It's been kind of about, I mean, I would agree with you, it's about the same either way, but I would say here in Arizona, Dr. Johnson and I, for those viewers who are watching, are both in the state of Arizona. And I would say, in my experience, it has been difficult for adults as well in both Medicaid populations and non-Medicaid populations to get into outpatient therapy. So that's something that often, creates that revolving door situation in an integrated setting as well. Um,
There,
Go
there
ahead.
is, sorry, there is another resource that I meant to mention earlier.
Mhm.
It's called Raising Special Kids.
Mhm.
That is a very good resource for parents that have kids with an IEP or any type of developmental delay or disability.
Mhm.
They'll they have various services, but they can help you advocate also if you are having issues. Um,
Mhm.
talking to the school about the IEP or anything that is helping, like blocking them from getting access to services.
That's great. Is that a web resource? Like, could people Google raising special kids?
Yes.
Okay.
They at one before COVID, they did have it where you could go in and take classes. They
Mhm.
also have, I'm sure they're all virtual now,
Mhm.
although I don't know, I
Okay.
haven't checked now, but I'm sure because
Yeah.
everything's virtual. Um, they also have a mentor program for parents, so
Hmm.
they'll try to match you with another parent that's gone through the thing that you're having a hard time with,
Mhm.
whatever it may be.
Yeah,
Um, and they'll match that parent with the other parent so they can help them navigate through that.
that's great. I know that's a big need. My population is maternal mental health, and so I work with a lot of moms with, young who are pregnant or postpartum or who have, small children at home. And for those that I work with who have small children are, birthing again and have an older child with autism or other developmental delays or pediatric needs, chronic needs, having a mentor or a peer support is a huge part of the healing and, just resourcing process. So that's a great resource. I'll look it up and I'll share that link in the post that we do to make sure that folks can access that link.
Yes.
Tell me a little bit about the needs of your general population other than, autism and maybe, screening for anxiety and depression. What are some of the chronic diseases or the comorbid conditions that you see pretty frequently that you realize there's a behavioral health component to?
There's to be honest, there's a lot of parenting,
Mm-hmm. Mm-hmm.
which is not comorbid, but that is probably the brunt of what I get, even though it's disguised as something else.
Yeah.
There is, I see a lot of kiddos with ADHD
Mm-hmm. Mm-hmm.
and ADHD. And like I said earlier, I have to try to assess, is this trauma / anxiety or is it ADHD?
Yeah.
I see kids that are overweight.
Mm-hmm.
I think that's all I'm thinking. There's, kids that come in with anger.
Sure.
Um,
I have a
yeah.
question for you. Are you noticing that you're starting to see fewer kiddos labeled with things like oppositional defiant disorder or conduct disorder now that we know more about trauma? No.
I hate that I have to say no to that question, but that's very discouraging and disheartening to me.
Mm-hmm. Yeah.
Yeah.
What do you think we can do as doctors of behavioral health or as integrated care providers to make a change in that area?
I recently read The Body Keeps the Score,
Mm-hmm.
and I know there's a chapter in there about this very issue where they had tried to get that into the DSM, that diagnosis, like I think it was acute trauma. I might be saying it wrong, but
Yeah, there's an acute trauma response in the DSM and then the ICD-10.
okay. So if that's already in there, then that's not it. But they were trying to get like a specific diagnosis of trauma
Trauma related issues.
other than what's in there
Mm-hmm.
to address that,
Mm-hmm.
what you're speaking about.
Yeah.
And they didn't let them do that.
Mm-hmm.
But as far as we're fighting the system, I feel like.
Yes.
And
And I think there are other states, for example, California's ACEs Aware organization has rolled out an excellent provider training and a site training for integrated pediatrics. I will provide the link to that, in the information for this episode. But they're doing a great job incentivizing providers to get ACEs trained so that they can, really think about what they need to do on site to increase the trauma-informed care elements, including staff and provider training and, the multidisciplinary team and how to connect better with local resources so that they can link families into care instead of, labeling or diagnosing and, sending kids back out without that, comfort support net.
we did all have the ACEs training at Canyon.
That's fantastic.
Yes. And obviously I have had that training for years and years now. But I see in Arizona, there's a very heavy, in the children's system, this is what I see, there's very heavy weight put on the psychiatrists. And I'm going to say particularly psychiatric nurse practitioners. that, in my opinion, don't take into consideration family dynamics and these experiences that children have had,
Sure.
traumatic experiences, and so they're just looking at diagnostic criteria that say, oh, check yes, check yes, check yes, but not taking into consideration the big picture. And if you did take that into consideration, you wouldn't just go down the line and say yes. You would say, oh, this is trauma, and ask different questions.
Right, right.
And so when these kiddos get those diagnoses, they stick. And instead of looking at this, like maybe later on coming back and saying, hey, this really is trauma, let's take a look. And it's very difficult.
Yeah, yeah.
Get them to relook at it and take off those prior diagnoses. They usually just put another one on top.
Yeah.
Which is not appropriate, but that's what happens.
Yeah, yeah. In my clinical practice, when I did mostly pediatrics and school counseling, we often referred to kids with all the D's behind their name. ADD, ODD, CD, ADD, ADHD, conduct disorder, obsessive compulsive disorder, on and on and on. And like you said, I too had the experience of these sort of stick. These don't go away. They don't get replaced by, I've met your family. You no longer meet criteria for any of these things that I see just at the surface. Yeah. So what about chronic conditions such as asthma? And, I know you mentioned obesity. What are some of the ways that you work with some of the medical components of care?
I know you were asking that. I really don't see kids with asthma.
That's actually really good.
Yeah, not that I can't even remember one time when I worked at Mountain Park for my internship. I did. A lot of people with kiddos with asthma, but
yeah. Tell us a little bit about what that looked like for you. What is an opportunity that sometimes I know for, folks who maybe aren't as well trained in clinical integration with behavioral health as perhaps Mountain Park is. I noticed, when I started my practicum, that often the depression, the suicidality, and the anxiety would get to me. But they would forget to make referrals for things like adherence to, managing asthma at home. They would forget that I could be useful in those ways. Talk a little bit about what that was like for you at Mountain Park.
So what I remember is really helping them understand the medicine that they were taking, and how to take it, giving them the instructions, demonstrating that with them. And then like you mentioned, setting a time, every day at the same time. Or, if a kiddo, obviously they're not going to take their inhaler every day unless they're under
Sure.
But maybe in a situation like that, they're, making sure they always have their inhaler with them, and who could they talk to, identifying a grown-up at school or even at home, if parents work, that they could speak to if they go into distress.
Sure. Yeah. I think that's something that, just the prescription of medication is one thing, but to help the child learn, and one of the populations I worked with was the population of kiddos with type 2 diabetes at Chandler High School. And a lot of times there were just problems that the kids hadn't shared with the school nurse, hadn't shared with their parent, hadn't shared with anyone because no one else that they knew, was insulin dependent. But they would just be problems that remained unresolved. And so, for example, if they had a regimen of coming to test blood sugar at school at lunchtime, sometimes they wouldn't come because that's their only time to be social with friends. So then they would eat, typical lunch portion food type at high school, which is probably for most high school students going to be something along the lines of pizza.
I was gonna say, yeah.
French fries, maybe a milk, but often more likely a soda. And so blood sugar, not happy. And then, by the time that they would get home, they would either be exhausted and go to sleep because they were in, food sugar or blood sugar coma. And then that caused problems with their grades. They were often missing assignments because they just didn't have the energy to get through. So I saw a lot of opportunities for a doctor of behavioral health to really make a difference. And I found that it was about sitting and talking through the minutia of those small problems in, a diabetes regimen or an asthma regimen, that self-care that a 14-year-old just doesn't know how to do. And then the consistency and repetition of checking back in and following up with the kiddo to make sure that they understood it and that they were actually applying it. And if they weren't, why, what was getting in the way, and can we problem solve to see if we can maybe accomplish that goal too. So it's not what most people would consider therapy, but it is certainly therapeutic.
Yes.
So tell me a little bit, because one of the things that often gets in the way of pediatric integration, and it is certainly something that's gotten in the way of being able to expand integrated care practices in pediatric settings in Arizona, is the funding, how positions are being paid for. Tell me a little bit about how Canyon is paying for your position, and how do they do billing?
So let's see, we finally now have an EHR, and I get billed under the physician.
So it's an incident to type of billing. Yes. And that is something that I have seen work so well here in the state of Arizona. That is definitely how I've been billing for the past 3 years in a midwifery center. And it's such an excellent way to bill for behavioral health. Unfortunately, it's not in any of the billing models that you'll see online. I have yet to see any incident to billing guidelines. And I think that's something that people are really missing out on when they want to bring a DBH or a behavioral health clinician on board. And so for those of you who are listening or watching, incident to billing is incident to, TO, is the type of billing practice, and it is actually billing for a secondary healthcare provider, such as a licensed counselor or a physician's assistant or nurse practitioner under the physician's license. And so there are specific CPT codes that can be used, and they refer to the level of service that's being provided, usually measured by the amount of time spent with the patient combined with whether or not a physical biometric was also measured at the time of the appointment, including, was a prescription made, was a prescription managed, and the consultation with the medical team, all of which is, part and parcel of pretty much every interaction that a doctor of behavioral health would have with a patient and medical team during any visit. Yes. And so it's a wonderful way to do billing in an integrated setting. So I'm glad to hear that Canyon is making good use of that. I have actually had physicians in the state of Arizona tell me that they thought that incident to billing for behavioral health was illegal, and have, told me that I shouldn't be doing it. They've said, I've talked to my billing manager and it's not possible. And yet, other billing managers will tell you, I've worked with the healthcare insurance company and this is all above board. They know exactly what we're doing. They read your notes, to verify that you are doing what you say you are doing with a patient. So it's really interesting. I think funding is still quite a barrier for a lot of providers who would really love to be doing integration. And I also think that's another opportunity for us to advocate together, provider groups.
I was going to say, the owner of the clinic, who did go to school to be a DBH, hasn't finished quite yet, but he did.
Mhm.
Uh, he, let's see, how do I want to say this? He's like experimenting with it, pushing it through,
Mhm.
you know, and some of the insurance would pay it and some wouldn't. And then when it would come back and they wouldn't pay it, he would,
Follow.
talk to them about it. Yes, follow up and, make a case for it. And just, little by little, it
Mhm.
starts, it goes through and
Mhm.
it goes through more and more now.
Yeah, and that's exactly what we saw at the midwifery center as well. Here, we definitely experienced, I would say probably maybe 30% would be denied initially, and the billing, department had to go back and negotiate with them, or we needed to provide more of a rationale. With United Healthcare, they wanted a specific sentence included in the notes that were behavioral health, and so all we had to do was create a template with that sentence in it to make sure that for those patients they were covered. And it essentially just notified, that more than half of the visit was spent in counseling and care coordination. And that's what we do. So it made perfect sense, for what we were doing. And it was just a matter of communicating with the insurance company about what they wanted to see. There's a way
Absolutely.
to do it, and I just continue to encourage people not to give up and to begin to experiment with it. You're not going to lose your shirt. You will figure it out.
Yes.
So okay, well, I think we're about out of time here, but I wanted to ask one more question, and then maybe we could even do a follow-up, Dr. Johnson, at some point. If a pediatric practice were considering doing behavioral health integration, what do you think are some of the initial things they should include in the planning process?
I definitely think that it's important to talk to the physicians about what we are and what we do so that they understand who to send over and who not to. I think that's such a huge part. And for them to want to send it over. And we have to, and it sounds so simple, but we have to just develop those relationships too. So that's on our side, on the DBH side, we have to know that this is different for a lot of physicians and it's not what they're used to and it's probably not what they like. So we have to understand that and meet them where they're at and develop a relationship with them. Um, and show them basically that we're there to support them and to work with them, and that makes their job easier.
Absolutely. Yeah.
The PA that I work with, I mean, we're an excellent team. I mean, she's like, "Can you help me please? I need you to work your magic," and so I'll go in there and I'll figure out what it is and I'll bring back the report to her and she's like, "Phew,
Yeah.
I knew it. Thank you so much."
Yes.
Thank you so
Yeah.
much."
So
We're at that point now.
that's great. And I'm so glad you brought that up because it may not be natural at first. And, I've hired a couple of behavioral health consultants who didn't have training as a DBH, but I was supervising and training them, and they get very nervous
Mhm.
about joining in as part of a team, building relationships. If they get snipped at or if they get told not to do something some way that they did it, they often feel like, oh, they don't want me here. And I just keep saying, you have to persist. You have to view it as part of your job to build a trusting relationship with the providers and to keep in mind that it is your job to support their role. You are part of the team, but you are not the leader of the team. And, it's really important for you to be in a support role. So sometimes that means providing training in a 5-minute hallway conversation or while you're sitting in the team, staff lounge, snarfing down your lunch and also charting and also consulting with the team. So getting comfortable, coming in and sitting down and just, charting alongside your providers inevitably consultation opportunities will come up. And that is a key opportunity, I think, for us to do a little bit of that. We train you to be more like us, and you train us to be more like you.
Yeah, absolutely.
Yeah.
Really quick, really quick. Along those lines, there, the pediatrician at my clinic, I noticed that during COVID, there's a lot of families that would come in complaining about their kids' behavior was bad.
Mm.
Well, why do we think that is? Because they didn't provide any structure. They were like allowed to go to bed at any time. That was before school started back in home. Um, and I just noticed, like, we need to remind parents that it's not natural for kids to stay inside all day.
Right.
They need to go outside. You need to provide an opportunity for them to move their body. They need to be active. Kids, like, it's just as important as eating and sleeping. And that I did a lot of that, providing structure, like, let's get a routine back, let's get sleeping back on track, let's get exercise back in there. But telling him too, like, hey, every time you have a chance, remind your parents to make sure that they let their kids play, actively every single day.
Mhm.
So,
Yeah.
that was, and he was like, yeah, okay, yeah, sure, yeah, you're right. you
Yeah.
know
Yeah, I think I love that so much. And I'm just recalling my son's 15-year-old annual, wellness check that we just recently had. And, we covered a lot of ground in the, maybe 20-minute visit that we had. There's a lot of measuring, and, they did a depression screen and talked with him. It was a depression anxiety screen, but I don't know what it was, but it was a piece of paper, and she handed it to my son and I didn't see it. And I gave him, privacy and confidentiality so that he could fill that out and, talk to her privately if he wanted to. But I'm just thinking, we did talk about physical activity. She did ask, are you, getting some activity? Are you going outside? And he talked about how he's swimming and, that kind of thing. So that is such a great thing to be talking to pediatric patients about, from, the medical perspective, as well as the behavioral health and mental health perspective. There's been a lot written about that during the pandemic, how people are recognizing more and more that nutrition, sleep, and physical activity, just being outside, as well as being with other humans, and as safe as possible as we can be right now. But how important it is. Sorry, I didn't hear you.
and structure.
Structure, absolutely.
I got that in there.
Yeah, and as you brought that up, I appreciate that too, because talking with some of the moms that I work with new babies as well as toddlers at home, they would often say, I'm not really sure, like, how do I get through the day and keep a toddler entertained as well as breastfeed my baby all day long, which is a full-time job. And so I would talk a little bit about the importance of that structure, and thinking about the time before we have lunch as well as the time after we have lunch, because I did preschool teaching for a while, and I would say, here's kind of a couple of ideas about, we would just do like a little bit of a morning activity and then a snack, and then maybe a second slightly structured morning activity, which could be, we just play outside in the backyard, and we have little stations set up in the backyard for them to play. And then we come in and we have our lunch, then we try a nap, and then we do this, and even just talking through minimal structure like that was very helpful to moms. So I totally agree. I really agree. Yeah. Well, Dr. Johnson, thank you so much for joining me today. It's been a really fun conversation. I always say, with another DBH, I could talk all day.
Yes, it was amazing.
So we'll definitely invite you to come back again and talk a little bit more on this topic. But for now, this has been a CGI Disruptive Innovators podcast, and we invite you to check out our next episode next week. Thank you very much.